would be talking about the lesion preparation, and they wanted me to talk about the long diffuse lesions. So over the last 1 year, I had been using DCBs for almost, primary intention is DCB. So compared to DES, the primary intention is DCB. My interest in the DCB started about exactly a year ago, when I had to chair a session by Goran Stankovic on bifurcation lesions. So Dr. Praveen Chandra, our good friend, was doing the live case, and then we were thinking it was a 1-1-0 case, and then we were thinking whether he will do a provisional stenting or will he end up with a kissing balloon and all that. So we had a presentation by myself and Dr. Goran, and then we were talking about the virtues of provisional stenting over a two-stent strategy. Then to my surprise as well as to Goran's surprise, so Dr. Praveen ended up doing a drug-coated balloon for the LAD diagonal bifurcation without using a stent. Then I asked him one question. Where do you not use drug-coated balloons? Where do you not use drug-coated balloons? The answer what he gave was very startling to me. He said that drug-coated balloons I don't use in the reimbursement cases, like the government cases, the scheme cases, or where the person cannot afford, then I go for the drug-coated stent. Otherwise, for all cases, a drug-coated balloon. And when we are in the as a chairperson, we always will have a different insight as compared to when we are in the audience. So I realized that I should try to start using this technology, and over the last year, I have learned some points which I would share with you, because whether it's a bifurcation, whether it's a diffuse disease, whether it is a left main or a thrombotic lesion, the end result is how you prepare and how you avoid a stent and why you should avoid a stent. So the why you should avoid a stent, I think there was some discussion by Dr. Anil. I would like to once more emphasize that we had the bare metal stent, we had the drug-coated stent, and we had the drug-coated stent second generation, third generation. So when they compared across the 3 time zones, it has been shown that despite having a better and better stent technology, beyond 5 years after implanting a stent, still we have a 2% failure rate per year after the drug-coated stent. So drug-coated stent is not the full answer for this problem. That also convinced me to start using the drug-coated balloons for majority of my patients. Having said that, we always encounter once in a while a restenosis with a drug-coated balloon or a drug-coated stent. We need to understand how we can prevent the restenosis also. That's only by preventing the proper preparation of the lesion. So that is the presentation of this talk. So I would share you one case. It is not a what we call a diffuse disease, but you can see here that there is a ostial LAD, and then this gentleman had a MI and a ostial LAD stent, and he had a circumflex lesion. So when you look at the case here, you can see the stent is up to the ostium of the LAD, but still if I want to put one more stent, that becomes a little challenging. So this patient, what I did was, we used a scoring balloon. You can see a 4013 scoring balloon, and then go up, and then after that we put a this is the scoring balloon dilatation, and following that I will show you, this is the solution SLR, and then this is the final result after the angioplasty with the stent. So we have a ostial circumflex lesion, which Dr. Pratap was talking, like this patient who had after a few months had a restenosis or a new stenosis in the circumflex. So how do we prepare these lesions? So that is the most important thing. I had like diffuse disease, where we can do a spot stenting and do a DCB for the entire length of the vessel, and a spot stenting, and we can just do a DCB also. Like that, multiple strategies. We can have a hybrid strategy versus DCB alone, or a metal jacket. So we have to choose what the patient would have. So the adequate lesion preparation, we should avoid a threatening dissection, we should avoid a good expansion, And this is about how we relearn the balloon angioplasty. Whenever I work with colleagues, they are very much apprehensive. Once we do the balloon, there will be some dissection, and if I don't put a stent, the person is going to have a potential for stent of vessel thrombosis or acute occlusion. But honestly, over the last 1 year, I think I must have done about 123 or 124 only DCBs. We never had a acute vessel occlusion. So what are the tips in preparation of this lesion? We should always achieve a 1:1 balloon to artery ratio. So 1:1 balloon artery ratio, and before we perform the angioplasty or the balloon dilatation, we need to give liberal nitrates and other vasodilators to maximize and choose the appropriate sized balloon. Especially if we are doing acute myocardial angioplasty, you want to avoid a stent, especially a young person. So we need to give lot of nitrates, pre-dilatation with a smaller balloon, and give lot of nitrates, and then only take the lesion preparation balloon. So prior to DCB, what we need to understand is we need to inflate the balloon for a long duration of time. So most of the time we have to do for 1 minute balloon dilatation, or many times I do for 2-minute balloon dilatation. So when you inflate the drug coated balloon for 2 minutes, you will get lot of ST changes, patient develops hypotension, patient develops angina. So those changes, you should understand how is my right coronary artery. If I block the LAD, what is the blood flow from the other territory? So that assessment also has to be performed, without which we will not be able to do. So aiming for the 1:1 vessel ratio is not important, but we should adequately inflate by using enough pressure. So what is enough pressure? So enough pressure means in our angioplasty stenting era, if your vessel does not open well, what do? You go to 16, 18, 20, even 22, like that you try to inflate, or you take a non-compliant balloon and then post dilate. So you can go very high pressures. But when you are going with a drug coated balloon, you should avoid a high pressure balloon dilatation. So you need to know what is the enough pressure. You should not go very high pressure, you go gradual upping of the pressure rather than. And then you should cover the entire length of the lesion, and we have to do repeated inflation and different balloon positions. So we are going to cover the lesion with a drug coated balloon which is longer than the length of the lesion. So we need to understand that we have to dilate the lesion before and after the lesion. So that is why that is one of the important. So you need to prepare the entire length of the lesion where your drug coated balloon will be deployed, or will be used to deliver the drug. Now what are the problems? One is a calcified lesion, or after you do a pre-dilatation there is a recoil, or there is a vessel threatening dissection. So let us understand how you can avoid a undilatable lesion. We should avoid very high pressures. We should particularly avoid the dog bone effect. So for example, you are getting a dog bone, just stay there 8-10 atmospheres, use a non-compliant balloon, wait at 6 or 8 or 10, and don't go very high pressure. Just allow it repeated balloon inflation rather than very high balloon inflation. That's number one. Gradual increase and repeated inflation, and consider always a non-compliant balloon. So don't use a semi-compliant balloon. Don't use let us say you have a 3 millimeter vessel, don't try to use a 2.75 balloon. Use a 3 millimeter balloon, a non-compliant balloon rather than a semi-compliant balloon. For example, our non-compliant balloon is not working, then you should have a very low threshold to move on to a cutting balloon, or a scoring balloon, or a intravascular lithotripsy, or a rotational atherectomy. So this is the way how you should do. The other very important trick what we can always employ, use a OPNNC, where you can go up to 30 or 34 atmospheres, or sometimes I went up to 42 atmospheres, also 44 atmospheres, to break the lesion. So a very heavily calcified lesion also we can break with a high pressure with an appropriate balloon. Please do not take an inappropriate balloon. Then one more trick what I have learnt over this time is, I started using a, it's not a commercial promotion or something, I started using a scoring balloon which is non-compliant, that is from Nipro. So, where I can go up to 14 or 16 atmospheres if there is a lot of still stenosis there. So, do not use a semi-compliant, use a non-compliant, non-compliant to scoring, scoring or cutting, cutting to a IVL or a rotational atherectomy, and then you can still avoid a stent. So, that is very important for you. So, for example, you use a non-compliant balloon here in this patient, and then you can see that there is a residual stenosis. We use a scoring balloon. After the residual scoring, then after the scoring or after the IVL or the aperta, you go with a high pressure balloon again, and then only use a DCB. So, this is the undilatable lesion algorithm what I follow. Then sometimes recoil is there. If the recoil is less than 30%, do not worry. If the recoil is more than 30%, we can repeat the balloon once again, but higher pressure with the same balloon for longer time. Then if the recoil is much more significant, then we can use a dedicated balloon like a scoring balloon or a cutting balloon. We have multiple balloons like either the cutting from the Boston or Nipro aperta or lacrosse balloon, all those things are available. So, then we this is how, if you have got a recoil, please always use a scoring balloon, and then followed by that we can use a DCB for this patient. So, once you do a DCB, some degree of residual dissection or some degree of residual lesion, do not worry about it, the patient will tolerate it well. As one of our colleagues was telling that whenever you have a dissection, previously in 2008, Dr. Anil was leaving the dissections there and using only a balloon dilatation. So, we have been more into the coronary angioplasty era, stenting era. So, we do not get too much we get anxious, and then you have a very low threshold for the stents. Now, for example, if there is a dissection, let us say you did a balloon angioplasty with a non-compliant balloon or a IVL or whatever device you use. After that, you have got a dissection more than grade 2. So, any dissection more than with a persistent contrast which is there at the level of the dissection, you should stent it. Do not think that DES and DCB are two independent things. You are just trying to avoid a stent. You can just put in a stent if there is a complex dissection. So, that is very important. So, whenever there is a vessel threatening, sometimes after a DCB, we have to cross over to a stent. So, when the dissection is type A, type B, you do not need to worry, but if there is a persistent contrast staining, you need to stent it. So, I will sometimes if you have a dissection like this, still after a follow up you get the dissection to be better. Why I wanted to share with you is, once we use a drug coated balloon, we have a phenomenon called as positive vessel remodeling. So, once you have a positive vessel remodeling, you will be surprised that you do a repeat angio after 3 months, the vessel will be sizing much larger. So, that will be very useful for the long diffuse lesion. So, you do something like a what we call as an investment procedure in CTO. Similarly, once you do a balloon angioplasty with a drug coated balloon, the vessel size increases over time. As we have already discussed, in a drug coat, in a bifurcation lesion, we can do for the main vessel, side branch, but majority of the operators traditionally stent the main vessel and DCB the side branch, but nowadays we can do DCB for both main and side vessel, and we can do all sorts of options. And kissing is very rarely required in DCB because you are not putting a stent. So, you do not need to open up the stent set. So, your bifurcation angioplasty becomes much more easy compared to that of a this one. So, now let's have the checklist. If the patient is free of chest pain, no ECG changes, and you have treated an enough length, then we use a drug coated balloon. Many times I have to use a Guidex catheter, though that is also very important. DCB profile will be little larger than that of a semi-compliant and a non-compliant balloon. So, we might have to use a Guidex. Do not try to advance the balloon and try to push it, but use a Guidex and then go down and then do that. And then TIMI flow should be achieved, and you should cover the DCB for a longer length. And if you have got any doubt, wait, take more time, do the angio, and you can wait for the patient has got angina, ST changes, and then be gentle with your inflation, and I am certain you will do well. Now coming to finally, we have got both Limus as well as for the paclitaxel. We can choose based upon what we do, but when we are using, it is always better we use a new generation stent. Similarly, new generation drug coated balloons which have come up in the last 2-3 years are much more superior compared to the first generation DCB. So DCB is there for a decade, but still current generation of DCB is much better, where we have a microsphere where the drug gets lodged there and will stay there. With this, I will open to questions. Thank you very much.